Regarding cardiac syndrome, the spine ends at L1 and L1 to L5. These nerves are in a pocket like a horse tail and are in the canal, surrounded by dural sac. Any compression at these levels is can cause a cardiac syndrome, which consists of bilateral leg pain, sedal anesthesia, bladder and bowel disturbances, um, and decreased rectal tone or voluntary contracture. Um, as it has been shown in that more than 200 of ml of post-void bladder scan is accurate predictor of cardiac syndrome. Moreover, Balasubramaniam in Middleborough has shown that sedal anesthesia has more predictive value in diagnosis cardiac syndrome. This can happen due to any space occupying lesion in the lumbar spine. That can be a disc, spinal canal stenosis, a tumor or infection, or epidural hematoma itself, or an abscess. And the study of choice is MRI scan, and the treatment is a bilateral extensive laminectomy, or I will say paravertebral approach. Meta-analysis has shown that surgical intervention within 48 hours um, improve better urinary and rectal functions than delaying the surgical intervention for more than 48 hours. A study from Leicester, published in European Spine Cohort 2007, showed that symptoms of spine prior to surgery does not influence the outcome, and there is a better outcome in patients who are continent to urine at presentation compared to those who are incontinent. N.V. Todd, a Newcastle study showed three different categories: early cardiac syndrome, impending cardiac syndrome, and retention cardiac. So early is the one who has a sensory-motor deficit without incontinence. Impending is an incomplete urinary disturbance, and retention is when there is a complete retention. Similarly, there is a study which has shown that this 48 hours rule is not a strict rule, and a good laminectomy is important.